Welcome to the podcast. I'm Robert Levine, a periodontist from Philadelphia, and today I'm excited to be joined by a true leader in oral maxillofacial surgery, Dr. Michael Pikos from Palm Harbor, Florida. My co-host tonight is Dr. Ismael Khouly, who is dual trained in periodontics and oral surgery, who practices in Miami as well as in Southern California. Mike is internationally known for his work in implants and bone regeneration. He's a master clinician, a dedicated educator who runs the Pikos Institute for Advanced Education for over 35 years. Mike is a trusted voice in our field, known for blending surgical excellence with real-world, evidence-based decision-making. Michael, it's a real pleasure to have you with us. Welcome. To start, we'd love to hear a bit about your story and your journey, where it all began, the key mentors who shaped your path, and how those experiences ultimately led you from the Ohio State University to the coastal jaw surgery in Florida.
Thank you, Robert. Indeed, it's a pleasure and honor to be here with this particular episode for AO. I really am impressed with the previous episodes. And with that said, regarding my journey, it really all began in Campbell, Ohio, which is a small suburb of Youngstown, Ohio, northeastern Ohio. And for the first 10 years of my life, raised really with my maternal grandparents in one house, along with my parents, two sisters, and uncle. So 8 of us in one house. And I look at that house today, I just shake my head, how did we do it? But they say it takes a village to raise a child. And honestly, it was a wonderful experience for those 10 years. We just moved a few blocks away then. My dad, the carpenter and a welder, built a house for us. And so the impact of the grandparents was significant. My grandfather walked literally 4 miles every day to the Youngstown Sheet and Tube steel mills and walked back every day, no car. My dad, 2 jobs, a carpenter and a welder, and watched him from 4 in the morning till 10 at night. So physical labor, but education was impressed upon, our mind so much. And that was driven. So through high school and college, did well, valedictorian in high school and summa cum laude, Phi Beta Kappa, all that good stuff. But my college career was kind of convoluted, to be quite honest. I wish I could say I want to be a dentist from a kid, but not true. It was more by elimination. Honestly, I began in petroleum engineering, pre-med, medical school for a year, saw a couple little guys die. I wanted to be a pediatric physician and realized that, that's not going to work. So took a little time off, and dentistry was basically what's left for me to do. Biology, biological sciences, patient, people. I liked all that. So dental school at Ohio State, yes. And then the light bulb went on during my second, third year in clinic. Surgery was impressive to me. Did a GPR, surgical base in Miami Valley Hospital, and then residency oral maxillofacial surgery in University of Pittsburgh Montefiore Hospital, and then set up private practice in 1983 on my own, scared. Fear's a great motivator, but as it would turn out, things worked out quite well for me those early years. Took call at 7 hospitals. It was night and day, just craziness. And long and short of it is, ended up bringing in an associate and then another one. And before I knew it, implants really became something very important to me in the early 80s. In fact, in 1983, I placed my very first Corvin implant and placed about 1,000 implants during those 80s and into the 90s, continued the journey. And boy, I tell you what, it's just amazing how I look back, blink of an eye, how things work out in your life, even with a kind of an unbelievable series of events. But quite honestly, I feel very blessed because my first mentor really was my father, who instilled in me some solid core values along with my mom. And to this day, really made all the difference. And then fast forward to, and essentially we could really go to my first slide, and I can just make a couple comments regarding, my topic, which really spans 4+ decades, lessons learned. And next, the mentors that I can really zero in on and give so much credit for, among many others, to be quite honest, but 3 surgeons in particular, Tom Golick, Bob Marks, and Phil Boyne, just tremendous giants. Unfortunately, 2 of them are no longer with us. but learned quite a bit from them, no question. And then 3 implantologists, Lenny Linkow and Hill Tatum and Carl Misch. Unfortunately, all 3 are not with us, but the impact that they had on me, in particular, Carl Misch, taking all of his courses and learning so much from him at the time and making sense out of, in the 80s, we did things we didn't even know why we were doing them, and we had success to a degree in spite of ourselves. But then I began to learn the science of why things were working. And then finally, Pat Allen and P.D. Miller were still with us, and just tremendous impact on me from a soft tissue perspective. And I began my soft tissue learning curve in the 90s. These were the 2 gentlemen's names who kept popping up in conversation. I called them up, spent time with them, and wow, they just embraced me. And to this day, the best of friends. And I'm part of that perioplastic surgical study club that, Robert, I know you play such a key role in now. Next. So today, I'm very honored to be able to share some lessons learned over my 4+ decades of private practice, and look forward to the rest of this dialogue.
Yeah, thank you so much, Michael. So let me ask you, could you mind to share your perspective on phenotype modification, and when you suggest soft tissue augmentation with your patients as part of the treatment?
Sure, Ismael. That's a great question. Next, for me, in the 80s, it was a lot of overdentures in terms of edentulous type case studies or case types that I worked with. And from a soft tissue perspective, next, I learned quickly, I say quickly, it took about 7-8 years into the 90s, the impact and the importance of soft tissue with regard to immobility around these overdentures, whether they were tissue-borne or bar-supported, because I began to appreciate, the concept of periimplantitis, just the suction effect of the overdentures against unattached tissue was a problem. Next, so early on, it was autogenous grafting. And as you can see from that upper right image, got a little carried away at times with the amount of graft that I would, harvest and utilize. And of course, with creep, I began to understand, appreciate what creep was all about. And then spending time again with PD and Pat Ellen, I mean, goodness, everything started to come together. Next. So that lesson learned was all about attachment and the importance of periimplant attached tissue to minimize, if not prevent, periimplantitis. So that was a very important lesson learned. And next. So then morphed into using an allograft, specifically Alloderm. And that was 1997. I was able to dig out a case. I started working with Alloderm then. And since then, it's been amazing. The application, as you see here, is a vestibuloplasty medium. And I will say this, that when you see that image on the left with all that Alloderm exposed, there's quite an odor involved. So for the first 2 weeks, I do not see my patient and make sure that it's a minimum 2 weeks post-op, so the odor can be at home and out of my office. Next. And here you can see and appreciate the lower right image. That's a 15-year follow-up. And if I just showed that image, I would bet most anybody would say that's a free gingival graft for sure. But no, in fact, it's Alloderm, which quite honestly will typically relapse about 50%. So we want 5-6 millimeters of attachment. Well, I would basically reposition on average 10 to 12 millimeters. But here you see quite a bit of creep. Next. Here I did a split mouth, more or less pseudo study for about 5 patients. That middle image shows Alloderm on one side, and which is human, of course. On the other side is Nova Matrix, which is a porcine dermis. Result typically the same. No difference, same appearance. Half the time we'll see keratinization at the surface, half the time not, but immobile tissue all the time. Next. So,
Mike, can you go back one slide, Mike? Because I think this is important for the young clinicians, as a periodontist, as Ismael and myself. Could you comment on your wound stability, your suturing technique? Because I think this is very important when you're using and leaving this exposed, the ADM.
Sure. Absolutely. Great question. I kind of shied away from any mattress suturing for concern of mobility of the graft. So pretty much from day one, I like the fact of using a small P3 needle, low Castro Viejo, and 5-0 chromic, or in the last several years, even glycolon. But that's important to suture every part of that graft down, including the margins. And as importantly is that the flap itself, after it's repositioned, of course, apically, to suture that down with 4-0 chromic or again, glycolon.
Great. Thank you.
Sure.
Next.
Yeah. So lesson learned there was the ability to use Eloderm in such a specific and predictable mode. And of course, the literature, we can look at Licovicius, several articles published, most of them in 2015, I believe it was, and, showing nicely how the effect of increased tissue thickness to minimize any marginal bone loss around implants. So Eloderm could be utilized in this context. So it's kind of all or none, either all buried, all submerged, or all exposed. Either you're pregnant or you're not. There's no in between. It's black or white, no gray zones. Next.
So, Mike, I got a question for you. Please share your definition of success in full arch cases, and what pearls can you share from your vast experience, such as what has worked and what has not worked?
Well, that's a great question, and I appreciate that one very much because there's so much I can talk about, certainly. But in the time that we have, I'll comment on some important concepts here. The big one for me being this one of all on XYZ. Everybody knows about all on X. That's number of implants. But the way I see it, there's the Y and the Z, which takes advantage of, or includes, I should say, bone and soft tissue. And with my background in both of those arenas, it's kind of like the elephant in the room. Nobody seems to talk about the importance of these two items with our full arch cases. Next. So grafting, I think, is important for not just residual sockets, but certainly pathologic defects that are created in a number of our failed dentition cases. So to say that, this is really just a graftless solution and be puristic and say, I don't bone graft, I don't soft tissue graft, I think really kind of is misleading. Next. And again, cases like this where we have exposed threads, a thin alveolar process, and unless we're going fully palatal, this will happen. So to say, well, I'm just going to ignore this, and even in a thin phenotype patient, you can imagine the problems they're going to have later. So from a prophylactic perspective, autogenous bone to me is super important to be directly on the metal. And then, of course, over that can be a combination of L-Zeno with a true collagen membrane with fixation. Next. So lessons learned here, yes, the importance of bone grafting, X number of our cases, I think is very important. Next. And then from a soft tissue perspective, our good friend Eloderm, and in this video, just showing the effect of post-Eloderm grafting. It may look like mucosal tissue because the color's pink, but it's immobile, and that's the key, as we all know. So again, the impact from a perio perspective, again, having spent that time with not just Peter Miller and Pat Ellen, but many other periodontists over the years, I've enjoyed that true synergy among the disciplines, and really can't say enough about how important it is for us to be able to share our clinical experiences between specialties. Next.
So when you're doing a case, Mike, what is your thickness that you would like to see with soft tissue as well as with hard tissue after you've done a graft, for example, in soft or hard tissue? What is your goal clinically and radiographically upon healing?
Yeah, clinically, I like to see minimum 2 millimeters of increased thickness. With Eloderm, sometimes we actually get 3 millimeters. And when we, countersink our implants, place them subcrustally, a good millimeter or even 2 with our full arch cases, well, then we can minimize problems later from that, from the issues of, again, exposed abutments, et cetera. And again, that's taken time for me to learn that. So lessons learned here, not just bone, but again, the Z is soft tissue grafting, so important. And again, to say that, thin phenotype patient, long face syndrome, for example, thin alveolar process, imagine that, we're placing the minimum implant diameter we can find that houses MUAs, which would be today's day probably a 3.3 millimeter implant. But in thin alveolar bone, you can see the translucency of the metal through the bone, and then a thin phenotype, close it and say, I'm done, have a nice life to the patient, and worse yet, no hygiene maintenance follow-up. Wow, that's a time bomb waiting to go off. So for me, that's a veneer graft all day long, L-Zeno, true membrane with fixation to protect certainly the underlying thin plate and overlying tissues. Next. So, lessons learned here. I just really have a problem with the concept of a graftless solution. With all due respect, I think it's misleading that to say that we don't graft at all is not true. For me, at least 30-40% of my maxillary cases are bone and/or soft tissue grafted, and as well as the mandibular cases, not so much bone but soft tissue. Yes. Next. And now, full arch lessons learned. My goodness, photogrammetry was a mega game changer for me 8 years ago. We are now, let's see. Are we good?
I'm back to the beginning there. Jim, can we get back to that slide that we were on? Yeah, it's an iCloud issue.
You were talking about photogrammetry and the importance of that. And for me, that was about almost 9 years ago now. And all I can say on that is that, boy, it's a game changer because now we're so digitally based from a restorative perspective with full arch cases. It's really been a very positive impact for us. So from a restorative perspective, I'd say 90% of our workflow now is truly digital.
How is the phenotype impact on those larger implants like the zygomatic implants to minimize complications? That now I think is one of the hot topics.
Yeah, well, what I'm able to do, and there's at least 4 strategies that I like to follow from a prophylactic perspective regarding minimizing morbidity, say, for example, with zygomatic implants in particular, because the dreaded triad of sinusitis and OA communication and dehiscence is real. So to minimize those problems, one strategy is using the buccal fat pad, pedicling it, into position over the zygomatic implants themselves. Another one is using bioheat PRF, which is extended PRF that literally lasts anywhere from 3 to 4 months or longer. It takes about 20 minutes to prepare, but I've kind of did a split mouth study in office with about 7-8 cases, half buccal fat pad, half of the bioheat PRF, and can tell no difference, but the increased tissue thickness, impressive. Another one would be a palatal roll that, if we're able to show that, looks like we've got our slides back up. Great. So next, there's our photogrammetry we talked about. Again, the impact for precision to make our workflow so convenient and be able to go right to printing, which we've done now for the past 5 years. And photogrammetry, we have to outsource that prior to having our digital lab, but it's made all the difference from a digital perspective. Next. So again, I was beginning to talk about PRF, I beg your pardon, buccal fat pad, and then extended PRF as 2 strategies of the 4, the other 2 being a palatal roll, which we can do a complete hemi-palatal roll, so to speak, as you can see with those images, and increase our tissue thickness dramatically on the buccal aspect of our flap. And finally, using a scarf graft, which is nothing more than a pedicle connective tissue graft that we're able to pedicle right into the and around the zygomatic implant. Next. So let's just quickly look at this case. This is Jocelyn. She was at the time about 65 years old, little Filipino gal. And as you can see, severely atrophic in both arches, one of the most severe cases I've ever treated. So if we look at the mandible in particular, I would rhetorically ask everybody, how would you handle that? Next. So for me, I've been very fortunate since 1990 to have taken a great course out in Leawood, Kansas, the Root Lab, to learn all about mandibular subperiosteal implants, which today are called patient-specific implants. Now, these are all done analog, chrome, cobalt, molybdenum, the first 15 years from 90 to 2005. I opened up the mandible, took a rubber base impression with a custom tray, and then poured up in greenstone, sent it to the lab over the phone. We would design it, and then it would be waxed up and cast in Vitalium, chrome, cobalt, molybdenum, and then sent back to us. Second surgery 6 weeks later, open up, place it, fixate it, and quite honestly, over 200 cases strong now, actually 220 plus. These cases just work so beautifully with minimal problems. And the reason being, from a soft tissue perspective, I learned early on how to handle soft tissue and increase it in advance of even some of these, actually in advance of placement of the implant itself. Next.
So your recommendation, Michael, is to do, because most of these cases have little to no attached gingiva after all these years. So your protocol would include doing the augmentation prior, by what, about 6-8 weeks prior to this procedure?
Actually, 3 months, exactly. Not in all cases, but whenever I sensed a thin mucosa and saw that, felt that, then for sure that would be in order. And the fact that, go back one slide, the fact that these transmucosal posts are polished and machined,
yeah,
you can see, and that made all the difference too. So even a relative lack of attachment over time, as long as the tissue was thick, not a problem. Yeah. So really an impressive way of handling these 5, 6, 7 millimeter mandibles that essentially would have been hip grafts and not predictable. Try BMP with mesh, good luck. 10-pull procedure in stem cell aspirates, etc. Just not predictable. Next. So published this book chapter in Vichy Bruman's, he was editor of this particular atlas just this past year. And really it explains in detail the entire protocol, both surgical and restorative. These are overdentures, mind you, but when they snap in place, they function as an FP3 prosthesis. Next. So what I learned early on, what I didn't learn at Root Lab, was my very first case. There I'm staring at this severely atrophic mandible, and I've got to get passivation of my flap. How do I do that? The mylohyoid muscle is right at the crest, and I'm not going to use sharp dissection. So I literally, all 4 of my fingers just started to, blunt dissection, separating superficial from deep muscle fibers, and that worked. And of course, buccal flap relaxation, used to that, not a problem. And so this so-called finger sweep, you can see the lower left images, we can get up to 30, 35 millimeters of increased tissue length, flap length. So great passivation of the flap. Next. So that was a lesson learned for me that, I can definitely get a passivated flap nicely, which then morphed into my bone grafting posterior mandible. And from 91 on, that became part of my institute courses, teaching this technique for closing over any type of augmented mandible, be it BMP, tie mesh, hip graft, etc. Block graft, would not matter. Next. So for Jocelyn in the mandible, this was staged. We worked on, I did her mandible first with the subperiosteal implant, which is, reason it works so well is on basilar bone. That's the key. It will not resorb. And 2 screws, typically anterior mandible, 1 in each ramus for rigid fixation. But most of the time, if there were undercuts, that framework would just snap into place. So that was never really an issue for mobility. Next. And then staging approximately 8 weeks later, quad zygomatic implants in her severely atrophic maxilla. And next. So the end result is a real nice upper fixed case against the lower RP4. However, although it's removable, once again, when that prosthesis is in place, for all intents and purposes, it's fixed. Next. So lessons learned here for me with that subperiosteal implant. a very predictable treatment modality for these severely atrophic mandibles. And I've got so many cases as follow-ups. This is my longest. It's almost really 35 years now. This young lady was only 42 at the time. And with cone beam CT from 2005 to the present, that two-stage surgery became one. So because of stereolithographic models, we can then just open up and place that framework beautifully in one surgery only. And that's what I've been doing the last 20 years now. Next.
So, Mike, when you look at where we started versus where we are today, how has your thinking about soft and hard tissue augmentation and when to do it changed the most?
Well, great question. I can only say that I'm so indebted to my periodontist colleagues, again, starting with Pat and PD and on down the line. I could rattle off about 15 names off the top of my head that I just love spending time with and exchanging knowledge. My strong background was with bone, their soft tissue, but then as we continue this a true synergistic relationship, and for about 16 years, Maurice Salam and I did Partners in Synergy. That was a very wonderful time frame where every other year we would get together and for 3 days basically cover a full spectrum of hard and soft tissue grafting from a surgery perspective, oral surgeon's perspective, from a periodontist perspective, and then what we would do in common. So that was just a tremendous time for me in my career. And again, the impact was so significant. So as you see in these cases here, nothing more than what I term a pedicle tunnel connective tissue graft, essentially a pedicle graft, connective tissue, but the incision, instead of beginning intracellular and going through the crest of the edentulous site, I just extend almost like a hockey stick. So that looks like a little tongue hanging out. But what it allowed me to do is with that connective tissue, it kept it intact better than if I opened up the flap completely. But what I learned was, my goodness, the importance of soft tissue augmentation in the aesthetic zone in particular, and impacted by, again, Robert, yourself, and so many other of my great periodontist colleagues, the importance of soft tissue in the aesthetic zone in particular. Bone grafting alone would not cut it. And I figured that one out again in the 90s and haven't looked back, and very grateful for that experience. And to this day, again, we continue to learn from each other. That's, I think, so important. Next.
Sorry to interrupt you, but I think that also for those young clinicians, I think that it would be nice to also mention that obviously it is important, as you well said, about that hard and soft tissue. And once that you got that, do not mess up with the restorative. And I think that now, in the last few years, they're coming out with that consensus of how that emerging profile actually impact on that soft tissue that you have built up, and also on the outcome of that bone remodelation around those implants. So we also have to keep in mind that restorative is going to impact on those outcomes.
No question. In fact, lesson number one learned that is in this whole series that I presented at the AMIS meeting, Dental Implant Conference last December. Lesson number one was, as Carl Misch talked about very many years back in the 80s, that and we've heard this many times over the years, certainly, that implant dentistry is truly a prosthetic discipline with a surgical component. So the restorative rules all the time. So what you said is profound, and you're certainly a master in the aesthetic zone, so you can appreciate very well what the importance of certainly of soft tissue, but again, playing off of the restorative. And so the everything begins with the end in mind, for sure. So yes, very important. From a bone standpoint, that's been my forte for so many years. Lateral wall sinus grafting is so still important. And unfortunately, folks who have bought into crestal sinus grafting with Versa drills, which I have used now for some 9-10 years, and made a big difference for me to even think about doing crestal sinus grafts. But lateral wall cases are still important to know how to do. This is a completely pneumatized set of sinuses next. And at that time, as you see here, and I had a complete tear Most folks would abort these cases, but I developed a technique in '94 to literally repair and replace a large or complete tear, not a problem. Next. And this technique really has made a big difference for me because I've not aborted any of my cases in now approaching 1,700 since 1989. In some cases, like in the middle, images might be hard to see, but I will splice two large cross-linked type 1 bovine collagen membranes together because some of these sinuses are so large. And then we tack externally, sweep internally, but not to the floor. And to make sure that membrane doesn't move, we can tack internally against the nasal wall. So that makes it rigid. And now we can go about our graft because we have the bony walls and the floor to feed the graft. Next. So now literature will tell us typically if you've got a large, or rather if you have pathology, remove it, put a membrane over the window and call it a day, come back and you'll have a membrane. And again, no disrespect to any of my colleagues. I'm just saying that ironically in this book of Ole Jensen, in this edition, chapter 8, we have that mindset. And then next, in chapter 10, we have the comments of, and again, this is perpetuated in our literature. If you have a complete tear, then abort, place a membrane over the window, and come back 7, 8, 9 months, have a baby, and you'll have a membrane. Well, I beg to differ with that. You may have a membrane, but it's so thin it's going to tear again. Next, ironically, my book chapter was right in the middle. Didn't realize it would end up that way, but I'm saying no, never abort. Don't have to, because we've got this technique that works so well. Again, a bovine type 1 collagen membrane that is cross-linked because it has structural integrity and won't break down for a good, 3-4 months. So it maintains itself. Next. So that's the technique, just animation-wise, cartoon-wise, in some summation, but it's so predictable. Next. Probably the single item that I've come up with on my own, gotten so much feedback over the years, so much correspondence that thanking me for this particular way of handling these perforated sinuses and large sinuses for that matter. And for those folks who say, just crestal sinus grafting only, we don't even have to teach these young folks anything about lateral wall because pretty much can do every case with crestal. Well, that's a major problem, I can tell you, for a couple of reasons, not the least of which is if you have a perf with a crestal sinus graft, now what do you do? I mean, a large perf, complete. And then secondly, tell me how you're going to take pathology out of that little crestal opening when we have large mucus retention cysts and other pathologies that mandate a lateral wall approach, et cetera, et cetera. So at any rate, I certainly don't do as many lateral wall cases as I've done in the years past because of crestal, and the VersaDrills have made a huge difference for me the last 8-9 years, no question. Next. So again, this case, a 10-year follow-up, you can see the grafted sinuses fine. And what we did in that day was 6 to 8 implants, bar over dentures, a ton of them, and they worked. You can lose 2 implants anywhere in that arch, anywhere. Pick 2 distal. That bar's still good, and the prosthesis is still functional. Next.
I like seeing, Mike, also that you kept some teeth there on the lower.
Yes.
So, as a periodontist, we do like to see that. So good job.
Absolutely. And again, I can't begin to emphasize the importance of the impact that your discipline has had for me, your specialty, because that definitely, and all along the way, I've been a very conservative surgeon to maintain teeth at all times, for sure. Next.
And this is much more maintainable. Just go back one slide, please, Jim.
Sure.
Much more maintainable as all the implants are axially placed versus on a steep angle, such as an all-on-4 concept. So,
yes.
Very nice.
Yes. Yeah. And again, you have a younger patient, early 30s. Would you want to do zygomatic implants in that patient? I mean, come on. Sinus grafts, wait your 8-9 months. That's fine. Place the implants, and then you've got beautiful axial alignment, etc. So this patient could be in their 30s, a meth addict. We have, a number of folks with drug issues and what have you. They can be rehabilitated, and then why render them to remote anchorage cases when take bone away? Not at all. Next. So lessons learned here for sure. This membrane repair technique is very, very predictable, and I've been teaching it for the past, 26 years, or 36 years, pardon me, since 1994. So it'll be 22 or 32 years, sorry. Next. So now, along with that lateral wall concept, I learned early on that, you know what, we need to look at lateral augmentation of the ridge. And the reason I say that is after 8-10 years, you know, when you follow your own cases, you get to see what happens over time. And I can tell you that it was alarming to me to see some cases coming back with abutments showing and periimplantitis, like, what's going on? And then I realized that, you know, my ridges were thin to begin with, paid no attention to that, let alone attachment, lack of. That's a bad combination. Thin ridge, lack of attachment. Guess what's going to happen? So began doing lateral augmentation simultaneous with my, ridge augmentation with lateral wall sinus grafting, as you're seeing here, very, conveniently, no problem. And that Daftari article next really put everything on the map for me in terms of appreciating that craniofacial growth does continue in all of us till we die. And when I first heard that lecture at AAP National Meeting, Academy Meeting, and heard both Daftari and Bahat talk about this, it was like, are you kidding me? So augmentation now, is super important because that resorptive element continues in all of us till we die. So the 2 millimeter, Uli Gruner talked about, and so many others in the aesthetic zone, sure. But you know what? We really need more like 4 millimeters, I would say. And to hear Bahat talk about eloderm usage, I mean, that's impressive to me. I mean, wow, here's a Nobel guy talking about a different product that, that could be problems from a main podium, but give him all the credit for telling it like it is. Augmentation, both hard and soft tissue combination, at least 4 makes a big difference. So that pretty much validated what I had kind of stumbled upon some years prior. Next. So lessons learned here for sure. Simultaneous augmentation of the ridge as needed with sinus grafting, I think, is super important to maintain those implants long term. Next. And it brings us to block grafts. I mean, I can say this, that since 1990, having done so many of these grafts, not nearly as many in the last, say, 8 to 10 years because of guided bone regeneration in particular. But I will say that these blocks do work. And next, to really say that because we don't split the blocks, i.e. the Khouly technique, that I know this has been termed a dead bone. It's white bone. See, because it's not cut, it's not red. So it's in essence necrotic bone. Well, if it's necrotic, I mean, over 1,000 of these later, I continue to do these again, not as many because of other techniques, but they certainly work. I wouldn't be doing them all these years and certainly not be teaching them. But Craig Mish, myself, and so many others have, big numbers of cases that for sure they work, but it's about biology. And I think that's so important for all of us to appreciate. For young clinicians in particular, anatomy is critical, but biology rules everything. And we can, abide by the so-called, principles that we're all grounded on. Well, then sure, we can get augmentations like this very predictably, case to case to case. Nothing's bulletproof, but we bat in the mid to high 90s with graft success, not so much implant success rate, because so many grafts are, studies are more or less referred to as implant survival and success. No, it's the graft itself. Is it turned over? Is it truly becoming bone that the patient can function with long term, et cetera, et cetera. So these grafts do work quite well. Next. And that brings us to BMP, which really for me has been, thanks to Bob Marks again, one of my big time heroes and mentors, having done now over 500 of these types of cases with time mesh and BMP, very predictable for two-dimensional defects, meaning not just horizontal, but vertical components too. So next, the fact that this is a mitogen morphogen, this is so important to appreciate. It's the only protein that can grow bone de novo. So if in fact we place this protein, say in your bicep or your femur, or your femoral muscle, it wouldn't matter if there's stem cells in the area, we're going to grow bone there. So important to appreciate the fact that we've got BMP at our fingertips to utilize here in the States, at least. Unfortunately, our European colleagues don't have the CE mark for that. So we have that luxury here. So BMP's made a big difference for me over time for a number of my bone augmentation type cases.
Thank you so much, Michael. So you were one of the earliest adopter of CBCT planning. As many implant complications occur due to planning or poor planning and or execution, how do you spend your time in the planning phase to avoid some of those complications?
Great question, Ismael. For me, it was 2005. Early adopter, yes, took a lot of arrows in my back because I really felt from the beginning that every case, every patient should be scanned. And boy, I tell you, a couple of main podiums, a lot of heated discussions, hey, Mike, how about the radiation and what have you? So I had to go through that. And fortunately, we had validation in due time that in fact, flying 30,000 feet, as we know, for less than an hour, or better yet, walk out here in the afternoon in Florida in the sun for a couple hours, and you'll have way more radiation than any one of our cone beam CTs, certainly. So the radiation element was an issue, but thanks to some important folks over the years that I've learned from, and David Hatcher is a dental radiologist out in Sacramento. What a pioneer that gentleman has been, and along with others who really showed beautifully the impact of CBCT. So it changed my practice, a complete paradigm shift from 2D to 3D. And that's 2005, 21 years ago. And again, haven't looked back since. The impact has been nothing but, of course, amazing. And to our young clinicians today, it's like no big deal. And it isn't, because it's been around now for a while. But early on, it was a tough one and there's a great series of images that we can, of course, utilize for all of our cases, for sure. It made a huge difference to be able to plan, no surprises to speak of, versus taking a Panorex in the old days and kind of winging it and playing off of what we would find intra operatively. Next. So the impact, yes, fast forward to our full arch cases, invaluable for certain, because this allows us, along with models that we're able to obtain from our CBCT images, from those DICOM files, we can now have a model, we have the scan, and there's really no surprises at all. We can plan our cases so well in terms of design, et cetera, remote anchorage cases. We know where the bone is, et cetera, et cetera. So really has made all the difference. So another paradigm shift for me and for many others, certainly, in private practice.
So Mike, on that note, could you describe your definition of wisdom, and how do you suggest younger clinicians to gain wisdom themselves?
Sure. Robert, I know we're on the same page with so much of what I've said already. And from a wisdom standpoint, the way I see it, young clinicians kind of chase technique a lot, and that's certainly great. But experienced clinicians respect anatomy. And I would say that wise clinicians respect biology. Yep. So with that said, technique will kind of get you started, sure. And anatomy will keep you safe, no question. But when all is said and done, it's biology that ultimately decides whether our case is going to make it or not. And then wisdom, as I see it, is kind of knowing which one is in control before you even pick up that handpiece. So where does wisdom come from, really? It's, certainly repetition, good mentorship, and understanding and learning from our complications, hands down. We all know that, no one's perfect for sure. And we can all, talk about our complications ad nauseum and what we learn the most from, certainly. But when you combine that with, with humility and integrity and honesty, well, then that's it. Wisdom, sure, will happen.
I found that documenting cases from the beginning of practice, years and years ago, as you have, really is helpful in wisdom, because you could really see what you did 10 years ago and how you would do things today. So how could you recommend documentation for younger clinicians who may not presently be doing it?
Sure. Photography is huge. Photography in today now, my goodness, it's simple. It's easy. The old days of slides was very labor intensive and cumbersome, and lugging those carousels. To this day, I've got a weak left shoulder. Had to go through some physical therapy and avoid surgery, but lugging those, because I did, like a lot of our colleagues, we did tool projectors at a time, and I carried the long guys, not the 4-pack but the 6-pack, and those were heavy with 120 slides per carousel. So a lot of weight, and of course you don't check those in, right? They went overhead. The luggage went underneath, but not the slides. So
TSA.
Yeah, oh gosh. So photography, today is nothing, and that would be huge, along with certainly our cone beam CT workups. So we have so much ability to document, and from a medical legal perspective, it's really important as well today, for sure. Not just for our own learning purposes, but certainly to protect ourselves. Yes.
One last item, Mike, before we move on. If you could leave clinicians with one mindset shift that would most improve long-term outcomes, what would it be? Like one last pearl, kind of a summary.
One last pearl. I would say that it would be very important to appreciate the following, and not everybody might buy into this, but the way I see it, all of our cases are going to fail. You have to look at it that way. No matter what we do, if a patient lives long enough, I do believe that, with rare exception, there's going to be problems. So with that said, I think our mindset should be doing everything we possibly could know from a prophylactic perspective early on with all of our cases, from a bone and soft tissue perspective, certainly from a planning perspective, our design up front, the prosthesis that we have in mind from the beginning, et cetera. All of this should be done in a manner that, we are going to want to have belts and suspenders more or less at all times. Now, that's easy to say, and I understand folks can't always afford everything we want to do for them, but within reason, we can do quite a bit. In the full arch case in particular, like I keep talking about this XYZ concept, if we zero in on the bone and the soft tissue, okay, so it costs a little extra time and money. You can build that into your fee. That's not the issue. It's, do we want to make that case last? And therefore, hygiene maintenance then becomes a huge part of that equation. So again, for full arch, you know what? So many of our colleagues, different corporate centers in particular, they don't follow these cases. You know that. It's one and done. Have a nice life. Here's your teeth, and good luck. And you've got a nice car, but you have no place to get gas or oil changes, on and on. So that's a problem. So not to sound holier than thou, it's just that with time you realize the importance of this prophylactic approach. And then part two of that equation would be, just, again, assume that patient is your spouse, your child, your grandparent, maybe not your mother-in-law, but no, just kidding. But my point is, it's somebody near and dear to you. So if you look at it from that perspective alone, along with the fact that the case, the younger that patient, the more apt they are going to have problems later. So we want to be conservative, but yet aggressive in terms of what we do from again, any perspective possible to maximize long-term predictability.
Terrific. And from our standpoint, also try to save as many teeth as we can before we start sharpening them.
Definitely. Very definitely. Many patients come to us thinking they need full arch, and they sure as heck don't. Yep.
So before we close, we'd like to share a few book and audio recommendations that are insightful, inspiring works that encourage reflection, curiosity, and growth. As we in America are celebrating 250 years as a free nation, we saw the Artemis II liftoff today successfully, which is unbelievable. So it feels really especially meaningful to revisit ideas around leadership, innovation, lifelong learning. It's the same principles that guide us as clinicians, professionals, parents, and also grandparents. So a quote from NPR: read a book, take a hike, reconnect with an old friend. 3 keys to happiness. Next. And if you've been following our series, starting with Will Gianoble and Lorenzo, myself, back in number 5, we're on number 10 now, we were recommending books. So you could take a screenshot of this, learn about wisdom, learn about everything health, learn about history, learn about what we like to read on away from the practice. So, Mike, could you discuss briefly the 3 books that you recommended here for Hot Seat 10?
Sure, it'd be a pleasure. These are 3 of my favorites. I love to read. I truly enjoy, lifelong learning truly is part of it for me. And I know so many of us buy into that as well. There just isn't enough time in the day for all of the books I want to read. So certainly audio books are in order as well. But for me, these are 3 of my favorites that I've read more than a few times. As a Man Thinketh by Ellen really is a classic. I mean, no doubt about it. This one, for me, had such an impact because our brain really is where it's at, and how we think is so impactful. And as a man thinketh in his heart, so is he. That's really from Proverbs 23:7. I remember that number because my birthday is July 23rd. So flip it, 23:7, Proverbs, very profound. This man lost his father at age 15. His dad had come from England to the States and unfortunately was robbed and murdered within 2 days of being in New York City. So he was left without a dad. Mom couldn't read or write. Long story short, the kid ended up being a journalist and published over 20 books, I believe, total. But this one was published, I believe, in 1903. It's a great book. It's really all about how our thinking impacts literally everything we do. So very important there. The Life's Greatest Lessons, my all-time favorite. I've given this book away many times over the years, continue to do so because I know it will have an impact on others as it has for me and for my own kids. That this originally was written for this gentleman's 3 sons. He was a school teacher and he was divorced and wanted to make sure his boys, he wrote letters to them, and all these letters over time, he accumulated them and decided to just put into a book form because the original title, I believe, was 20 Things I Want My Kids to Know. And long story short, now the 4th edition is the latest edition. It sold many copies. And there were really several reasons that he wrote the book, as I'm remembering. One of them was that, you're never too old or too young to learn these life's greatest lessons, these core values that unfortunately are, I think, being lost in this day and age by so many folks. And then secondly, that they don't teach this kind of thing, in school. What's essential about all these core values, so to speak, really aren't taught anymore in school at all. And that we can also appreciate that, the goodness in all of us. That's a third reason he wrote the book. And then finally, the old-fashioned, more or less approach of let's put it this way, in a nutshell, the old-fashioned values never really go away. They're still there. So that was the impetus for him to put this together, and it's a solid book. I tell you, I think it should be read by everybody and kids in particular. It's timeless. And last but not least, the last lecture by Randy Pausch. He an amazing young man. 2007, he gave this lecture. He gave the last lecture, which was an ongoing series at Carnegie Mellon University, and he decided to do this talk knowing he had pancreatic cancer, knowing he was terminal, and that he would be dying within a year, which he did die that following year, 2008 in July. But the impetus of that lecture really wasn't so much for his audience as opposed to for his own 3 kids. So it's really about more or less intentional leadership and living, and not so much how to live a meaningful life, but not so much how not to die. And that was really the take-home message. And over 8 million copies now have been sold, I believe, and that video is available certainly on YouTube. I would strongly recommend anybody hasn't viewed it to check it out. It's very humbling. So these 3 books for me really impacted me tremendously, and the core value concepts that I think are so critical for all of us, regardless of where we are, where we live in the world, are important for us to continue to have as a mainstay.
Thank you. Ismael, you want to talk about that? Start with why?
Excuse me?
You want to talk about your book recommendation? Start with why.
Yes. So those are some of the book recommendations that I have. With the Start with White. There are also some other recommendations that I also like, even though they are not over there, that normally I share also with some of my students. I think that one that I got a very good feedback is the Anatomic Habits, which is an easy and proven, build up, obviously good habit and change. I think that one is pretty sure probably really nice for those young clinicians. And also the 7 Habits of Highly Effective People. Again, this is also an older book. I think it's like around 30 years already over there. But I think that those are great books for, I think, young clinicians as well.
Great. Thank you. My recommendations are just some of the Grant Douglas, The Patriots I just finished, Codebreaker. Just some really outstanding Americans, really heroes of many people, including myself. So still waiting for the musical about Grant. It should be coming out, hopefully. So, all right, next slide, please. I want to just announce that on June 17th, about 6 weeks from now, Mike Sonic will be my guest with Briar Boy, Treating People, Not Patients, The Importance of Establishing Human Connection. And that's a book that, as you do as well, Ismael, give out to residents. It's one that I've done for the last few years since it was published by Michael, dear friend of mine for over 35 years. So join us on Wednesday, June 17th, and it'll be at 8 o'clock p.m., again, Eastern Time. And lastly, Michael, I want to say, let's go to the next slide. Michael, thank you so much. Ismael, thank you. If you want to have some closing words, it's all yours, Michael.
Well, thank you. Indeed, again, it's been a pleasure and an honor to be on this hot seat. And this closing slide really puts it all in perspective for me, because it is all about my family. Many folks have talked to me about my legacy and that type of thing, and wanting to hear me talk about my institute of now 36 years, my private practice of 43 years, et cetera. And I say, no, time out, pump the brakes. No, my true legacy is really my family. And I've been blessed to have, an amazing wife of now almost 39 years and 2 amazing kids. They're both periodontists that practice with me. And because of those 2 individuals, my daughter Lindsay, my son Tony, we've got 6 beautiful grandkids, now ages 8 months to 8 years, and 3 of them live next door to us, and the other 3 are just 35, 40 minutes away. In fact, tomorrow is Grandparents' Day. Robert, we were talking just briefly before this the program about that, and I look forward to that for the full day. We have breakfast, and then the programs in the morning, and then lunch, and then over the house, and then dinner. So it's a full day, but we get to see them, fortunately, often because they live so close. So to me, honestly, I mean, that's really my legacy, is my family, and I've been very blessed over the years to, again, have had the impact of grandparents to parents, certainly, and now the beautiful dynamic of grandchildren. And I know, Robert, you have some, and it's an amazing experience for sure. Ismael, I pray the day will come for you too, and you'll appreciate also what I'm trying to really share with our audience. So been very blessed.
So on that note, Michael, thank you. Ismael, thank you. And we'll all see you June 17th for our 11th Hot Seat. Everybody have a good night and a great spring.
Thank you.